Okay. And let's see. Okay, so let's start our second part. And this part we will talk about ischemia basics. Okay. We will cover what is ischemia in general, what is myocardial infarction. Is there any difference between the two words or not? Okay, and what are the signs of ischemia, and usually what is the next step for if we detect ischemia, what we should do. Okay, so let's start with the ischemia. Ischemia is hypoperfusion. Okay, hypoperfusion usually means there is no adequate or there is no enough blood supply to an area of the body or an area or an organ of the body. Okay, this is hypoperfusion or ischemia. Is it a localized hypoperfusion or is it a generalized hypoperfusion depending on the state of the patient? This hypoperfusion or this ischemia might lead to death of the tissue, okay, that is affected by this ischemia, okay, and this is in the case of the heart, we call it infarction. So in scientific terms, cardiomyocyte necrosis, okay, necrosis means death, okay, in a clinical setting consistent with acute myocardial ischemia. So the patient usually will have hypoperfusion to the heart, either due to a block or due to another problem, usually due to a block, okay, or insufficient problem in the coronary, insufficient blood supply in the coronary due to a problem in the coronaries itself or in the body as a whole because of a sepsis, for example, or something like that. Okay, this might lead to myocardial infarction or death of the cardiac myocyte. Okay, if death happens, then we call it infarction. If death doesn't happen or did not happen yet, okay, then it's an ischemia. Okay, so this is the difference between the two terms or the two words, ischemia and infarction. Okay, so what we are looking usually on the ECG, what we are looking for, okay, to suspect an ischemia, okay, in relative to the patient presentation. Usually there is no one specific sign that says the patient is ischemic or the patient has acute ischemia now. Okay, and as you can see, there are multiple changes that we can see in the ECG. So for start, we can see completely normal rhythm and completely normal ECG, and this has a 10% chance that the patient has an acute ischemia happening now. Okay, despite that the ECG looks normal. Second change that we can see is a T wave abnormality, usually a T wave inversion. The T wave, instead of coming up, usually goes down. Okay, we will see this, for examples for each change in the coming time. Okay, and then there we will see an ST depression. This has a 50% chance of ischemia, and ST segment elevation has an 80%, and ST segment elevation for in some leads and depression in other leads, then this has a 90% chance. You can notice that there is more percentage that says 100%. Okay, not even the highest percentage that we have is a 90%. Okay, and this supports that the ECG is not a black and white. It's not a yes or no tool. It's a suspicion tool, depending on presentation of the patient and the complaint of the patient and how things started and how things are going. Okay. So how do we suspect ischemia in a patient? We usually depend on our patient. So we have a triangle. The base of the triangle is the patient. Okay. So the complaint of the patient, what are the signs, okay, of the patient that are present in the patient? And then we have two other arms to the triangle itself. The one arm is the ECG, and the other arm is the heart enzymes, or we usually use troponin here for it. Some places, some other places might use troponin and other enzymes as well, but usually, let's say heart enzymes in general. Okay, so our base is the patient, okay, not just the ECG, not just the enzymes. Okay, and the patient will come to you with a complaint. Okay, so we take this complaint and analyze it into certain, according to a certain, let's say, steps or certain criteria. We can use different mnemonics to assess the complaint, but usually we like to assess it using the old cars mnemonic with 4 A's in car. Okay, so each letter in this mnemonic represents something, and as you can see, onset, location, duration, character, alleviating factors, aggravating factors, activity at onset, and is there any associated symptoms or not, and is the pain radiating anywhere or not, and how severe is the pain. Okay, let's apply this to a cardiac patient. If a cardiac patient comes in with acute ischemia or acute hypoperfusion to his heart, usually the onset will be acute and the location will be central in his chest. Okay, and the duration usually will last more than 15 minutes. Okay, not less than 15 minutes, because if it's less than 15 minutes, it might be just usually something muscular or some reflux, something else rather than the heart. If ischemia, if it happens, it stays. Usually it doesn't reverse back. So the patient usually will, the pain will last more than 15 minutes. The character, as you can see, sometimes the patient can say there's something heavy and much on my chest. My breath is not the usual. There's a pain, dull aching. I can't specify what's pain like, and etc. There is no specific character to the pain. Although the most famous complaint about the character of the pain is the heaviness, like an elephant sitting on my chest. Okay. But usually this represents only just 25 to 30% of the character of acute ischemic pain. Okay. Alleviating factors next is usually when the patient rests, the pain will become less. And if he uses the GTN spray, for example, this is for vasodilatation, okay, and to dilate the coronaries a little bit and make the blood flow become much better, and this might alleviate the pain as well, okay. And aggravating factors, any type of exertion. Okay? That's why we ask any patient that might have a cardiac problem, please rest, don't move, don't do any exertion, please. Don't move even from bed to toilet. Okay, just stay as you are. Do everything while you are on the bed. Okay, and don't move around, just to relax the heart and make the patient in a rest mode, so we can decrease the demand that the heart should pump blood more, and then it will become much better for him. Okay, and decrease the demand for the heart to pump more blood. Okay, usually when this happens or the pain starts, it starts with a certain activity, like the patient was like, says to you, I was playing golf, I was walking from my home to the supermarket, or coming back, or whatever activity he's doing. Okay, usually it will be what we call an active duty or active. The patient will be active during the start of the pain. But let's say this is not all of the cases. Some cases the pain can start at rest as well, especially if the patient has multiple risk factors and like that he has ischemic heart disease, hypertension, diabetes, and if he especially had heart attacks before, or he's prone to bad coronary status. Okay. When the pain starts to the heart, usually it activates the vagus nerve, and the vagus nerve will give the patient nausea, vomiting, and sweating as well. We call cold sweating. If, like now, we are in a very good weather, we shouldn't, the patient or one of us, if he's resting, he shouldn't be sweating. But if the vagus nerve somehow is activated, it will give you sweating, and this is what we call cold sweating. Okay. Radiation. Next step for the R. Okay, radiation. The heart is in the center of our chest, so it can radiate to the back. Okay, just between our shoulder blades. It can radiate upwards to our neck or downwards to the abdomen. Okay, it can radiate to both arms as well. Okay, so and depending on the radiation, usually it gives us an idea how bad the ischemia is and where is it. If the ischemia is in the inferior wall of the heart, usually it will radiate to the epigastric area. If it's in the interior wall or the posterior wall of the heart, it will usually radiate to the back of the between the shoulder blade. And this might give us an idea about how the where is the ischemia is happening and how bad is it. Okay, and lastly, the severity of the pain. This is very important question because usually we forget to ask about the pain. Usually our attention goes away from the pain and we focus on the ischemia itself. Let's give the patient aspirin, let's give the patient anticoagulation, let's rush the patient to the cath lab, and we usually forget about the pain. And one of the main treatment corners for in such patients is to decrease the severity of the pain if it's severe, and the patient should be pain-free. Okay, in these settings, because pain usually activates the sympathetic system and puts the patient under what we call makes the patient anxious. Anxiety will demand the heart to beat more, and we don't want this. We usually need the patient to be pain-free so he can rest, and we will decrease the demand for the heart to pump more blood and you work more, and we don't need that. We want the heart to be as relaxed as much as we can, so it doesn't require more blood to be perfused to it to replenish the nutrients and oxygen to them. And it's just like a preventive measure rather than a curative measure. Okay. So these are the points of the complaint. Okay, if you can just put these puzzle pieces together, then you have a very good suspicion for acute ischemia, and then you will look for signs. Signs will vary very widely between just lethargy, tiredness, something is not right, up to the confusion. Okay, and there is no specific. You can say there is no specific sign that we can say we will see it on all the patients. We usually will have different signs in different patients, and every patient will look different. Okay, so we have our complaint. We have some suspicion from the complaint that the patient has ischemia, and then we have our signs, and then we will do the next part of the triangle. Okay, and we'll do the ECG. Okay, these are cases, these of mine. I will we share them with you, and we will interpret these ECGs together and see if you can spot any changes or not. Okay, so prepare yourselves. I will do this. This is a 43-year-old male presented with chest and back pain. Okay, I remember this man because it was 7 a.m. that day, and he was about to go to his work, and suddenly he started, while putting his clothes on, he started feeling that his chest is not feeling well, and the pain started going upwards, and it's not coming back. At first he thought that it's just a reflux or something, so he tried antacids, but they didn't help, and then he decided to come to the hospital. When we have done the ECG, as you can see, okay, first thing first, standard ECG or not, yeah, 25 millimeters printing speed, 10 millimeters millivolt presentation amplitude, and P wave is upright in lead 2 and downright in EVR. So we have our standard ECG. Then we can apply our standard measures on it. So what about the heart rate? Heart rate, okay, it's not written here, so we will go for the next step and calculate it. We can say these are four big squares and 4.5. So we are speaking about 60 something, 70, dividing 300 by the 4.5. So we will have about 60, 70 heart rate. So it's normal heart rate. And then we will do the next step. We will look for all the waves. Are all the waves present or not? Then P wave, R wave, T wave, P wave, R wave, P, T, R, P, T, R, and it's all present and in a very good intervals to each other, very good and constant intervals. So we've passed the second point, which is the waves. Intervals looks okay, but for the first, but we won't speak about it here. There is another session in the future when we will speak about how to calculate each interval, and we will comment on them. But for the purpose of simplicity, we won't comment on them today. So, and the next step is I will look if there is any signs of ischemia that we have spoken about earlier today. Is there any T wave inversion, or is the T waves are pointing downward in places where they should point upwards? Okay, I can see. Sometimes someone will ask me about the T wave in EVR and V1. Okay, it's pointing downward. Is this okay? Is this normal? I can say yes, it's normal for the EVR and V1, and sometimes lead 3 can have a T wave that points downward. And if this is just the only leads, if these are the only leads that with the T wave that are just pointing downward, then it's fine. It's just a normal because of the angle that the lead is recording. Okay, not because of the ischemia present. Okay. Any questions about this young man? Okay. So let's go to the next case and someone can comment on it. Who would like to try? Come on, we need someone. Isaac, are you in a position to comment on this ECG?
Yeah, I can try.
Yeah, let's try.
Okay. we are all beginning. So,
Yes, okay. We were
so as you
beginners.
said initially, as you said initially, I need to check
Yeah.
the presentation of the patient and then the ECG itself. So let's assume that the patient complaint sounds more cardiac or it's a suggestive of ischemia. So you go ahead and do the ECG. I'll first check the standardization of the ECG. So
Okay.
I can see that beneath the ECG,
Yes.
I can see my 25 millimeters, then the millimeters per seconds, then the 10 millimeters per millivolts. Yeah.
Yeah.
Yeah. So I also check my L2 if my P waves are upright and
Yes.
compare it to AVR.
Yeah.
The AVR should have inverted P waves. So the
Yeah.
ECG is standard.
Yeah.
Yeah.
Perfect.
After I'm done with the standardization, I need to check the presence of P wave and then the complex, that's the KRS complex, and then the T waves.
Okay. There is a step before that, which
So the step
is
before that, I'll check the heart rate.
yeah.
So
Perfect.
I could see that the patient is a bit tacky because the normal heart rate should be from 60 to, let's say 60 to 100.
Yeah.
The patient has a heart rate of 108.
Yeah.
So technically, if the heart rate is not calculated by the machine, I need to check
Yeah.
it manually.
Yeah.
Yeah,
Okay.
by
Luckily
using
for us,
my
point it here.
okay,
Yeah. Yeah. Okay. So next step, we will check the waves.
the
Okay.
the waves. Yeah. So I could see the presence of the P waves.
Yeah.
And
Followed
then the
by
QRS complex,
yeah.
followed by the T wave.
Yeah.
You could see that they are all present
Yeah. And all present, all consistent. Okay. Perfect.
and they are consistent as well. Yes. Yeah.
Okay. Good. Good.
So to me,
Good.
I realized that this ECG is more or less normal. Yeah.
Okay, fine. I can see. We'll speak about each change, but this ECG, yeah. Thank you, Isaac, for this. Yeah. These are the steps. Uh, my main purpose for this lecture is just for you to interpret the system of thinking and how to interpret, not to find any abnormalities at the moment. We will just find it together as we go on. Okay, so as we started with the chest, with the complaint. Okay, so it's a 60-year-old female presented with chest tightness, and she also had some cold sweating, and she was nauseous when she presented to us in the hospital. And this was her ECG. And as you can see, it's just showing us that it's a bit tachycardic, okay, not that much tachycardia. And if we review the waves and review everything, okay, we can't find very major or can't find it's more or less normal or sinus tachycardia. Okay, all of these patients that you will see here in this lecture are have proven acute coronary syndrome and they all have gone to PCI and they have they were found to have a critical ischemia, and that critical ischemia mandated that they have a stent put their coronaries. So you can imagine how this might affect anyone. Okay, so another volunteer for this ECG. Oluwatosin. Are you in a position to try?
I don't think so, but I still have a lot to learn.
Okay, Anthony. Okay, fine. Anthony, would you like to try? Come on, guys, we need a volunteer here. This is an exercise-based session. Vivian? You have a big experience in so.
All right, I'll give it a go. Okay, so first of all, you did mention that you actually need to. Can you hear me, please?
So
Can
this
you
is
hear
a
me?
patient male, presented with chest pain. Okay, and this pain was central in his chest. It was radiating to his back. Okay, and also the patient had significant nausea, and he vomited twice as well.
Hello, can you hear me, please?
This is his ECG. Sorry. Pardon me?
Can you hear me?
Okay.
I was just going to give it a try, but I think you can't hear me well.
Okay, so let's go step by step. First thing is first, is this ECG standard or not? Okay, can you tell me if it's standard?
It's not standard. It's not standard.
Why?
No.
Yeah. Why do you think it's not standard?
I think when it comes to the standardization, we can't see the speed, we can't see the voltage as well.
Yeah, okay. We can see two things from the 2 points from the 3 points of standardization, which is the first point is the voltage, how the voltage is represented, either by it's written or it's represented by this inverted U wave, okay? And if you can count here how many U waves we have, sorry, how many small squares, let me use my mouse so I can a little bit make any problems here in accident. So I will just, if you can look at here, you can see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 small squares. Okay, so as we said before, as we said before, amplitude or 1 millivolt, okay, should be represented by 10 small squares, and this is our first point. Second point, okay, the speed. Unfortunately, we can't find the speed here because it's cut. And the third point is the P wave. The P wave should be upright in lead 2, okay, looking upwards, and inverted in EVR. Okay. So we have 2 points of 3, okay, and the speed, let's say it's 25 millimeter, and then this passes our standardization step. Okay. What's your next step, Vivian?
So my next step would have to check if it's a normal ECG. We need to have a look at the heart rate.
Yeah.
It's not written there, so we have to calculate.
For you, so I removed the heart rate as well.
So we have to do some calculation. I don't remember the formula, but
So you will usually pick 2 R waves and see how far are they from each other, and then you can divide 300 by the number of the large squares, how many large squares in between them, or 1500 by the number of the small squares.
Oh, okay.
Okay. So let's say these are 3 and 2 small squares here. Enlarge it for it. I will pick these two just for the sake of simplicity. Okay, so this is 1 big, 2 big squares, 3 big squares, and 2 small squares. And each big square has 5 small squares in it. Okay, so this will give us a total of 17 small squares. 15, so 5 by 3, and then 2. It will give us 17 small squares. Okay, if you divide 1500 by 17, we'll have heart rate of 80s. Okay.
Yeah.
80 something. Okay.
Yeah.
So it's within the normal range.
Yeah, sure.
What's your next step?
So the next step is to have a look at the PR interval.
Okay, so
which you said it should be between.
Not intervals, please. No intervals
Pardon?
here. No intervals here, please.
Yeah.
I'm looking at the waves. Okay, are the waves present? Are all of our waves present or not?
So it is, but it looks a bit fun. I think so. Let's have a look at the P
So if you can look
QRS.
P, QRS.
Yeah, and then
T
the
wave,
T wave. Yeah.
PRT, PRT, and they are all present and persistent and consistent. There's nothing missing in between. Okay, this is a complete yeah. Thank you, Vivian, for that. This is, as you see, yeah, this is a normal ECG. Okay, there is no T wave inversions in any position or anywhere that the T wave should be upright. It's not down, and everything looks okay for this man. This man found to have a very big occlusion in one of his coronaries. Okay, so let's go to the next change, and the next change we'll speak
Dr.
about
Man,
T wave inversion. Yeah.
please, I have a question with the previous ECG. Now, if you look at V2, V2 from V2, I can see there's wide. So after the complex, the QRS, I don't know whether it's normal here or not, but it's a bit wide as compared to the other ones.
Okay, how much wide do you think it is? So if you can see the start of it.
Not the
here.
QRS. So after the QRS, so it's more or less a T wave, this
the
one.
side of the T wave.
Yeah. T wave,
Yeah. You are speaking about the size of the T wave. Yes.
Yeah.
If you can see the size of each, this is what we spoke about earlier about the conduction. Okay, the conduction, as you can see, each lead looks at a different angle. Okay, and this angle from the angle of V2, the T wave has this shape, and the V3 has this shape, and it's different in each lead. Okay, but from the normal point of view, this T wave looks okay, looks normal. Okay, we will speak about this in the next, not today, in the next part. In the future, we going to worry about the size of the wave, but for now, this is normal. Okay, let's just trust now. Okay, I know you're not, you maybe not convincing, but just trust me for now. Okay. Okay, so let's speak about the next change. Okay, our first change that we can see in an ECG, which is a T wave inversion. Okay, in like for example in lead V V3. In this example, we have the P wave and then the QRS complex, and the T wave is coming down instead of coming up. Okay, so this is abnormal. Okay, I will start with the next, please. Yeah, I will start with this first ECG here. Okay, this is a 36-year-old male presented with a chest pain. Okay, an ischemic chest pain. From now on, all the ECGs are standard, and all the patients is just the complaints. As I said before, all the patients went to cath lab and they have found to be an acute ischemia, and they mandated to have a stents in them. Anyway, so looking at the ECG rate, to my eye, okay, I think it's more towards the bradycardic side. If we can just calculate how many ECG, how many big squares he's 1, 2, 3, 4, 5. So this is about 60 heart rate. It's within the lower normal. But if you can see here, there is a T wave inversion in V1, V2, V3, and V4. And all the rest of the ECG looks okay. Okay, so first step is first complaint. Second step is standardization, and we said it's standard. Okay, and third step, if I'm looking at the waves PRT, and they are all present. Okay, and then I am looking at the waves, still at the waves, if there is any change in their normal behavior or not. Okay. And from earlier, someone can ask me, you said earlier that V1 and AVR can have an inverted T wave. Okay, so why in this patient we considered the T wave inversion and sign of ischemia? Okay, because if you recall, I said earlier that V1 and AVR, if there is an T wave, they should be isolated without any other leads having the same change. If there is any other leads that has the same change, okay, like for example in this patient, we have V1, V2, V3, and V4 as well, then this is a significant change that we have to investigate and we have to look after, okay, and treat if needed. I'm sorry. So in this patient, okay, can you see or can you tell which wall or which area that these leads represent? Can
Is the anterior wall?
Yeah, perfect. Yeah, that's correct. Anterior wall. Okay, if you remember our. Okay, let me bring you the picture. Okay, if you remember this picture, you can see that V1, 2, and 3, 4 represents the anterior surface of the heart, which is just here, where you put them. Okay, this is. Thank you, Isaac, for this. Okay, this is our picture. Okay, let's see this patient. Who would like to give us joy? Would you like to try?
Not yet. I'm still trying to digest it.
Yeah, just give it a try. We're in it together. You don't have to make it right. We're just make it together.
I'm trying to see if it is a standard.
Yeah, so it's a standard. Okay, I just cut the standard a little bit just to pass this step, so we can jump straight to if we can find something abnormal.
Yeah, the T waves is inverted, which is supposed to be, but this second part where you have V1 and V2, this V2.
V2, okay. What's
no,
bothering you?
where you have this Roman numeral 2.
2, yeah.
Yeah, here. It's supposed to be. It's not right. I'm trying to remember the word.
Yeah, it's downward. It's pointing downward.
Yeah, so it's supposed to be point.
It's
supposed to be up.
Yeah. Okay. Is it just in lead 2 or in other leads as well? If you look at lead 3, yeah.
Lead 3, yeah.
Yeah. If you look at AVF,
yeah,
you can find it. Okay. So you can find it in these 3 leads. Okay. And 2, 3, and AVF represents which area in our heart?
The anterior? Yeah, the anterior.
The anterior is represented by V1, V2, V3, and V4. So
yeah, so the posterior is represented by
you can see here.
Yeah.
By the inferior side of the heart. So these represent the inferior side of the heart. Okay.
Yeah.
I will.
Okay.
Okay. Review this slide again. Okay. So V1.
Yeah, I just want to. Okay.
4, okay, represent the anterior wall. Okay. 2, 3, and EVF represent the inferior wall. Okay. V5 and 6 from the chest leads and lead 1 and EVL from the limb leads represent the lateral wall or the left side of the heart. Okay. And the only lead or the only camera that is pointing to the right side is the AVR. And the standard or the normal ECG that we do usually. Sometimes we can do right-sided ECG and posterior ECG, but the normal one, the only one that is pointing to the right side is the AVR. Okay. So in this ECG again, we have T wave inversion in lead 2 and in lead 3 and AVF, and this represents the inferior wall of the heart. So this will lead, let's say you can notice by now that we usually have to depend on changes that are present in 2 or more leads in the same wall. For example, if we have a T wave inversion in just lead 3 and let's say this example for this ECG, for example, we will just focus on the inferior lead. If you can see, there's an upright T wave here and upright T wave in lead AVF, but in lead 3, the T waves is pointing downwards. Okay, is this a significant change in this wall? The answer is no. Okay, it's not a significant change in this wall. because it's an isolated change in one and only just one lead. But if the change is in two leads in the same wall, okay, this is a significant change and we have to act upon it if we think this is an ischemia or something like that. Okay? Is this clear? Is this point clear?
Yes, it's clear.
Yeah, good.
Thank you.
Thank you. Okay, so another example. Who would like to try? Anthony, I think you can try this one.
Okay. I would like to try. So the only thing I can see here, as per checking the standardization, is the heart rate, which is 63.
Yeah.
But the interval is normal.
No, we are not speaking about intervals. Okay.
Yeah, but I cannot see the voltage anywhere.
Can you see the waves? Yeah. So you've started with your heart rate, which is correct, and then you go to the waves. Okay, and then the intervals. Yeah. So waves first.
Okay, so I think is the waves the same as the speed, isn't it?
Sorry?
The wave, it is the same as the speed.
The waves are the shape, these shapes, P wave, yeah, QRS and T waves. These are our waves. Are they all, so what I'm thinking about the waves, are they all present or not? Are they consistent, okay, or not?
Yeah.
They are all present and they are on a consistent pattern, okay, or not? And third thing in the waves, okay, is there any abnormal wave, okay, that is pointing to another position that it shouldn't be pointing to, okay? And currently we are speaking about the T waves in specific.
Okay, so looking at the waves, there is no, I cannot see any inverted T. Is it? No, I cannot see any inverted.
Okay. So for the T wave, they all should point upwards.
Yeah.
Okay. Yes. Okay, except in 3 leads, which are the AVR, lead 3, AVR, okay, and lead V1.
Yes.
If the T wave is inverted in these 3 leads, then this is normal. Okay. But if the T wave is inverted in lead 3 and lead 2 and EPF, like this ECG, for example, then this is not normal.
Normal.
This is not normal. Okay, because it involved 2, okay, more than 1 lead. Okay, basically, if you see a picture of my face, okay, with what looks like a wound in my face, you can suspect it's a wound. You can suspect it's a pin mark or something wrong with the picture. But if you see 2 pictures, if you see a view here and from my face and a view from the other side, and both are showing a wound, then you can say it's a wound. Okay. And just on one picture. This is the rule in ECG. If you can see one picture which is represented by one lead, so each lead represents or gives us a picture of the electricity of the heart.
Yeah.
If there is a change in one picture, okay, that is accompanied by another picture or another lead in this position, in the same area, okay, then this is, we can ignore this change. But if both pictures or both leads in the setting of an ECG shows the same change, then this is something significant that we have to investigate or act upon.
Yeah.
Yeah. Okay.
Yeah.
So, can you see any inverted T waves?
Yes. The V3, V4, V5.
Yeah.
Yes.
Good. Yeah. So you can see V1, V2, V3, V4, V5.
Yeah.
So all the chest leads, okay, are showing T wave inversion. Okay.
Yeah.
If I said to you, this is an ECG for a 63-year-old male came in with shortness of breath, will you be worried or not?
I should be worried.
Yeah, because we have a complaint and an ECG changes, so two parts of the triangle, okay, that showing us a positive changes for ischemia or positive suspicion for ischemia.
Yes.
Yeah, thank you very much.
Thank you.
Okay, so we can see a T wave inversion here. There is another subtle T wave inversion in AVF and lead 3 as well. Okay, as we said before, if it was just in lead 3 itself without any change in lead 2 and AVF, then I could ignore it. But in this ECG, we can see that the T wave here, okay, is also pointing downwards. So this are two leads in the same area. So this is a significant change for me. And V1 through V4 represents the anterior wall, and V5 and 6 represents the left side of the heart. 3 and AVF represents the inferior wall of the heart. So this doesn't look good, okay, for this patient. We can just escalate this patient and act upon what we have found. Okay, good. This is another example. Okay, can we have another volunteer? Okay. Josephine, am I pronouncing your name right? Or correct?
Hello.
Yeah, hello.
Yeah, you pronounce my name rightly.
Thank you.
Yeah. Okay.
Would you like to try?
So let's see.
This is a 55-year-old female presented with shortness of breath.
I'm trying to analyze it now.
Yeah.
Okay, so we don't have the heart rate, so we need to calculate the heart rate. Yeah. And looking at the waves, like the intervals, seems intervals are all within the same limit. We can't see any out of range interval here. And looking at the waves, let's see.
Okay. Is there any?
Oh, can you help me with the waves?
Yeah. Is there any wave? Is there any T wave in specific that is pointing downwards?
Yeah, so we've got 2, 3.
Lead 3. Lead. So let's start here. Lead 1.
Right.
Is it pointing upward or downward?
Down, but it's supposed to point up.
Okay, so it's pointing downward. In lead 2, it's pointing.
It's pointing down.
Up.
Down, and 3 is pointing up.
Yeah, up. Okay. AVR, we can tell.
You can tell, yeah.
In AVL,
also down.
Yeah, it's pointing down. Okay. AVF.
Yeah.
It's pointing up.
It's pointing up.
Yeah. Okay. And V1. Up.
V1 up, yeah. Up
okay.
as well.
Again, and up
Yeah,
in the rest.
4, 5.
Okay, so we have a T-wave
Down.
inversion. Yeah, in lead 1 and lead
Yeah.
VL. Okay, if we just say here, you can see here, we can see that lead 1 and AVL represent the lateral, the left side of the heart. Okay, so we have a change in the left side of the heart. Okay, so 2 leads in the same area of the heart. This is a significant change.
Right.
Okay?
Yeah.
Okay. Thank you. Thank you very much.
You're welcome. Thank you too.
Okay. So we have seen the normal, okay, and that we can't find any change, and we have seen the first change, which is the T wave inversion. So the T wave pointing downward where it should be pointing upwards as well. Okay, so we will now look at the second change, which is the ST segment. Okay, and if it's deviated upwards or downwards. Where is the ST segment? Okay. The ST segment, for a start, usually starts at the end of the QRS complex till the beginning of the T wave. So it starts at the end of the QRS complex and the beginning of the T wave. Okay, and this segment should be on the same line, the same baseline with the TP segment. Why the TP segment? Because this is the time where there is no electricity in the heart. If you can remember from the first session, okay, we said that the P wave, okay, when the electricity comes from the SA node down to the AV node, and then it stops here, and then it travels down, okay, the ventricles to give us the QRS complex and the T wave, okay, and then it stops, and then it starts again at the B wave. Okay, so the time where there is no electricity in the heart is in between the T wave and the B wave. So in this area, this is the time where there is no electricity in the heart, and this represents our baseline. Okay, why don't we use the PR segment, okay, or the ST segment to determine our baseline? Because there is an electricity in the heart, okay, and electricity usually will deviate the line based on how much electricity there is, or if it's moving or not. Okay, so we cannot use the PR segment or the ST segment to determine our baseline. Okay, so we have determined our baseline, which is the TP segment, and then we will compare the ST segment to it. Okay, are we comparing all of the ST segment? No, we are comparing the beginning of the ST segment, which is, we call it the G point or the junction point. The junction point is the point of the deflection or deviation from the QRS complex towards the ST segment, in this example, it's this point, okay, and yeah, this ECG is this point. This is the J point, okay, the point of deflection from the QRS complex to the ST segment. If the J point is above the baseline, then it's ST segment elevation. If it's below the baseline, this is an ST segment depression. Okay? And how much depression is significant? 1 millimeter in our standard measurement, and 1 millimeter, this will represent 0.1 millivolt. Okay? And as we said before, this change should happen in at least 2 leads in the same area. So for the anterior leads, we are speaking about V1 through V4. If I have 2 leads with ST segment depression, then this is a significant change. And this will raise our suspicion for ischemia up to 30%. Okay? Let's check our first example. Okay. For the heart rate, it looks okay. It's not tachy or brady. Okay, so it looks okay to my eyes. Okay, so I will skip this point, and then I will have a look if on the waves, are all the waves present or not. They are all present. Okay, PRT, PRT, PRT. Is there any wave, specifically T wave abnormalities? That is there anywhere that the T wave is pointing downward instead of upward, where it should be pointing upward? Yes, I can find that the T wave is pointing downward in lead 1 and lead 2. Okay, but the rest of the leads T waves looks okay. Then I will look at the ST segment. Okay, if you can look at here, you can find this is the TP line. Okay, and you can find that the J point is below the TP line here. And in lead 2, it's also the same, but there's significant space here. And also lead 3, lead EVF. This represents the inferior wall, and lead 1 and lead EVL represent the lateral wall, but it's not depressed in lead EVL. Okay, and B1 to 3, it's starting to be depressed in lead V3, J point, and TP line. Okay, V4, it's markedly depressed, and V5 and V6 as well. Okay, in EVR, it's the opposite way around. So this is the TP line, and this is the J point, and it's elevated. So we have an T wave inversion. For conclusion, we have a T wave inversion in lead 1 and AVL. We have ST segment depression in the inferior and part of the anterior and lateral wall as well. And we have ST segment elevation in AVR. Okay, in a patient that is a 56-year-old with significant chest pain and nausea and vomiting. Okay. Do you think? What do you think? What should be our next step for this patient?
I think it should give a strong pain relief.
Very
Yeah.
strong pain. Yeah, and okay, we would like to call the cardiology because we have an ST segment elevation, a stemming, okay, and that is represented by the right side, okay, and see if we can rush this man or fast track him to cath lab or not, because we have a significant ischemia that is covering multiple walls of the heart. So it's covering the inferior wall, it's covering part of the anterior wall and lateral wall as well. So we have a significant or a large area of ischemia. Okay. Okay, so here's the second example. like to try? Okay, we have new guests. Okay, interesting. Let's say Irene. Irene, are you in a position to give it a try? Okay, looks like Irene is busy. Sarah? Oh, you're back. Okay. Sorry, Irene.
Okay, so I'm just trying to understand the whole thing because I didn't join early.
Yeah, fine. We're here to learn. We're not here to. Yeah.
Well, I can see the intervals are all the same, if I'm right. And
Yeah. So in short, we are looking for any T-wave inversions or any ST segment depressions. Can you see any of these two changes here?
okay. With the ST wave inversion, I think I can see in lead 1, if I'm correct.
Lead 1, yeah, okay. There's a difference between the J point and the TP line. So the J point is down in this lead. Yeah, good. Okay. Any other leads?
No.
Okay. Let's go through them all and see if you can spot any changes on it. How about lead 2? Do you want me to?
Oh, okay. Thank you.
Do this? Yeah.
Okay. So yes, we have some in lead 2.
We have in lead 2 as well. Yeah. Okay.
Yeah.
How about lead 3? This is the J point. And
Okay,
this is
so
the
with the R wave inversion,
no,
it's just pointing down. Is that normal? I don't understand.
the T wave is pointing down. Okay, we will see. Okay, to say if it's normal or not, we have to see the rest of the wall. Okay.
Okay.
Lead number 3 is one of the inferior wall. Okay, leads which are 2, 3, and AVF. So if there is any T wave inversion in another lead with the lead 3, then this is a significant change. If there is not, then we can ignore it. Okay. So in lead 2, T wave is upright. In lead AVF, it's pointing, it's small, but it's pointing up as well. So we can ignore the T wave inversion in lead 3. Okay. So we have ST segment depression in lead 1 and lead 2. Okay.
Yes.
Lead 3, we don't have.
We don't have.
Yeah. J point is almost at the same line with the TP line here.
Yes.
So this is the point, okay, and this is the TP line. Okay, perfect. What about AVR? This is the T wave, this is the P wave. This is the TP line.
Okay.
If we go to here, you can find that the J point is above.
Elevated.
Yeah, okay, good. Okay. What about here in EVL? This is the TP line. If you just
It's
just depressed, okay. Okay, but it's not a significant depression.
Yeah.
Because it's almost less than 1 millimeter. Okay. Okay. What about AVF?
There is no change. I mean, it's
No change. Okay, good. That's good. V1.
elevated just slightly.
Yeah, good, good. I see. What about the rest? The V.
They are all depressed. No,
Okay.
except
In V2, it's almost on the
V6.
same time. Yeah.
Yeah.
And V3, V4, V5, V6. You can see this is the baseline, and the G point is down here. The same in V4, the same in V5, the same.
Yeah. Okay. Okay.
Set. Well. Okay. We go back. Okay. Can you recall which leads as which changes? This case it's an ST segment depression. So we have lead 1 and lead V3 through lead V6. Is that right?
So can I try?
Yeah.
Yeah.
So I think we have ST
Well,
depression.
Mm-hmm.
ST depression in the anterior wall of the heart,
Yeah,
and then the lateral wall.
Yeah, part of the anterior wall. Okay, and
Yeah,
lateral
the
wall.
lateral wall. Yeah.
Okay, and yeah. Okay, in if you can find this ECG with the, if you can just connect the ECG with the patient with who is a 67-year-old male with chest and back pain. Okay, so you can just say, yeah, we have a significant changes here with a significant patient, and then we can escalate. Okay. Okay, so another example. Who would like to try? Let's say Sarah. No, Sarah is not with us. Okay. What? Okay. Oluwatosin. Am I saying your name right?
Yeah, you're correct with my name. Yeah. Okay, let me see what I've learned so far. Because I joined very late.
Yeah, for the sake of simplicity and yeah, and to make things simple here, we will try on this issue. We'll try the chest leads only because the limb leads are a bit unclear on this side. So we will just try the chest leads.
So you want me to talk about the V1 to V6?
Yeah.
Okay. Okay, so if I check the interval of each wave from V1 to V6, they look in the same range for each of the waves. And I think we want to check for the ST depression here, if I'm correct.
Mm-hmm.
Okay. So for V1, the wave is inverted. I mean, the whole wave is upside down, if I'm correct. So, okay, hold on. I have to turn it. Okay. Okay. I think for V1 is normal.
Okay. V1, there is no. significant changes. Okay, fine. What about V2?
V2. V2. There is light for V2.
Okay, so we
for
about the J point.
Okay.
What? And this is the TP line. So this is the T wave. Okay, and this is the TP line, which is our baseline, and this is the J wave. Okay, how it's correlated to each other. You can see that the J wave is downward. Okay, if this is your baseline, the J point is down. So this is an ST depression in V2. Okay. What about V3? Oh no. Okay, so
am I correct? Sorry, I don't think you hear me.
Yeah.
Except for V3.
Yeah.
The J point is also depressed.
Yeah, depressed as well. Yeah. Okay, what about V4?
So V4, yes, on the second wave there is light.
Yeah, as well. Okay, and V5
is
almost the
I think
same
V5
line.
is almost the same.
Yeah. Okay. Good. And V6.
V6 is almost the same, but though there's light, but it hardly can I actually see it.
Yeah, it's slightly upward.
Yep.
Okay, so we have ST segment depression
V2.
in V2 and V3 and V4.
Yes.
Okay, perfect. Thank you. Correct.
Thank you.
Okay, so this is another example. Okay, if you can see here that we have, if I go through all of these, for all of the leads, I can say that I have a significant ST depression in from V3, V4, V5, and V6. Okay, and a T wave inversion in lead APL as well. There is also a slight ST depression in lead 2, if you can see. Yeah. Okay, and these are the significant changes that that are found in this ECG. Okay, if you combine these with the complaint or the patient, then we have to act upon it. Okay, good. So we have spoken about the normal, we have spoken about the T wave inversion, we've spoken about the ST segment depression. It's time to speak about the ST segment elevation, which is the opposite. Okay, as before, we usually compare the elevation and depression. We usually compare the J point with the baseline, which is the TP segment. And we have to have this change in at least 2 leads or 2 cameras in the same role to say or to take the decision that this is a significant change. Okay? This will apply to all the leads except lead V2 and V3. Because lead V2 and lead V3 are almost on the top of the heart, and usually they take a lot of electricity and they record a lot of electricity. So it will differ depending upon how the patient is. Is it a very thin patient, very obese patient, and will also refer on how old is the patient. So if the patient is a male patient, okay, if he's less than 40 years old, we usually allow an ST segment elevation or a J point elevation up to 2.5 millimeters in V2 and V3. Okay, if it's above this, this is a significant change for us. Okay, but if it's elevated 2 millimeters, let's say, and it is including V1 and V4, so it is including more area, not just V2 and V3, then this is a significant change. But if it's isolated to V2 and V3 up to 2.5 millimeters, then this is normal for a male patient less than 40 years old. He's little bit bigger, okay, than 40, then it shouldn't pass the 2 millimeters mark. And if the patient is a female patient, the ST segment elevation in lead V2 and 3 should not pass the 1.5 millimeter mark. Okay? So, again, we usually say the change is significant if it's just 1 millimeter above the baseline, okay, in two contiguous or two leads, the same wall. Okay, I will start with this ECG. Let me just skip it for the sake of simplicity. Let's just skip it. See this one. Can you see any ST elevation in this ECG? Someone might say, okay, I will just make it bigger. Start here. Lead 1, the J point is almost at the same baseline. 2 as well, 3, AVR, EN, EF. Okay, if I start to see here, you can see that V1, there is slightly elevation. V2 is markedly elevated, and lead 3 elevated as well. Lead V4 is elevated as well. Okay, V5 is almost normal. V6, the baseline is not great, so but it's here. It looks normal. Okay, so for this ECG, there are ST segment elevation in V1, V2, V3, and V4, which represents the anterior wall. Okay, and this is what we call it. We call it anterior STEMI, especially if the patient is coming with a significant ischemic chest pain. Okay, and we think it is an ischemia, acute ischemia that we should intervene with. Okay, so this is another ECG. Who would like to try? Vivian. Are you in a position to try?
Hello?
Yeah. Hello.
Oh, sorry about that.
Yeah, it's okay.
I can say lead 2 and then lead 3. Yeah, so looking at lead 1.
You like?
Yeah, I think that would do. Looking at lead 1.
If you're using your mobile, you can zoom in using your mobile as well.
Oh, okay. All right, that's fine then. In lead 1, I'm not really seeing a significant elevation in 1. Unless you are seeing something I can see.
Yes, okay, hi.
And then in lead 2, Nothing. Let me have a look at the other side. Nothing that I can see from my end. Oh, but in V2, when we move towards the other side, towards the extreme, is it right? Yeah, that side. Yeah, that side. Oh, yeah, around that side in V, is it V4? Yeah, in V4, I can see some elevations there.
We have a
very massive ones.
Yeah. Okay.
And then V5 in V6 as well.
Yeah. So V4, 5, and
V6.
6.
Yeah. In V6 as well.
What about
and
what the rest of these? V1, 2, 3.
So in V2,
yeah.
In V2, V3.
Yeah.
V2,
This
V3.
is the baseline. Okay.
And in V1, I'm unable to actually identify.
Yeah.
But then in V2, V3, V4, 5, and 6, there is a massive ST elevation there.
Correct. That's correct.
So I think this calls for concern because V5, V6, as you said, is actually 2 leads in the same area, which is the left side of the heart. And then V2, V3 is also 2 leads in the same area. So giving us ST elevation in 2 different areas of the heart, which calls for concern.
Yeah. So this is correct. This is a significant change, okay, in the interior wall and the lateral wall as well. So it's an ischemia that is taking the interior and the lateral wall, and it's a very large area to include. Okay, if I point, you can see it here because it's very massive, okay, and it's very large. But if I take your attention to the limb leads, you can see we can notice that all of the ECG, the amplitude is of the QRS complex of the waves are very small. Okay, but this means if there is any change, okay, like the one you can see here, this is the baseline. Let me take the point. Okay, this is the baseline, and the J point is slightly elevated here in lead 1 and lead AVL as well. Okay, so this is the baseline, and this is the J point. You can notice that it's a little bit elevated. Okay, given that the amplitude is small, this is a significant change as well. And this is also confirmed, okay, or supported by the change in the chest leads, because the chest leads has an ischemia to the anterior and to the lateral wall. Okay, so it's also reasonable to have a change in the lateral walls of the limb leads as well. Okay, so lead 1, AVL, V5, and V6 all look at the same area, which is the left side of the heart or the lateral side of the heart. Okay, so this is a significant change in a 61-year-old female with the gastric pain as well. Okay. So we've seen the ST segment depression and we've seen the ST segment elevation. So let's combine them together, okay, and see what we can have. So in this patient, for example, a 40-year-old male coming in with chest pain, if we look at for the T-wave inversion, ST depression, and ST elevation, we can find that the ST segment is depressed in lead 1, AVL, and slightly depressed in V5 and V6. Okay, and it is elevated in lead 2, 3, and AVF compared to the baseline. Okay, so when also there is ST segment depression in V2, V3 as well. So again, if we can review the heart area by area, let's start with the lateral area. So lead 1 and lead AVL, ST segment depression. In inferior wall has ST segment elevation. Okay, right side of the heart has some sort of ST segment depression. And the anterior wall has ST segment depression in part of it. Okay, in V2 and V3. And lateral wall in the chest leads has also some slight ST depression. So this is an inferior STEMI, inferior ST segment elevation, myocardial infarction, inferior STEMI with reciprocal changes with what we call a mirror image. Basically, let me grab something. If you can see me, this is the heart, and this is the inferior wall. Okay, so 2, 3, and AVF are looking here to the inferior wall, and they are all have ST segment elevation. Okay, if I am looking from the interior wall, okay, I might detect the mirror image of it. Okay, that's why I can see an ST segment depression in these leads. Okay, so sometimes the inferior wall might have a mirror image in the anterior wall. Okay, and you can also think about if I have an ST segment elevation or depression in the left side of the heart, I might see the opposite in the right side of the heart. Okay, so again, if we can see a change in one area of the heart, we can see the mirror of it. And the mirroring of it is called reciprocal change. Okay. Basically, it's ST segment deviation to the opposite side from the original area. In this patient, the original area or the original change is ST segment elevation, which is more significant for us, okay, is taking the inferior wall of the heart, okay, and it is reciprocating in the anterior wall as well and in the lateral wall. Okay, is this point clear? Or would you like me to re-explain it?
Please, can you re-explain it?
Yeah, okay. So let's say, for example, if I have two cameras, okay, so this is the camera in front of me, and there is another camera in the back there. If I come closer to the camera in front of me, I will be further from the camera back there. But if I come closer to the camera back there, I will be away from the camera in front. Okay, is this clear? Seems
yes.
Logic. Okay,
yes.
Perfect. Apply this, but in electricity. If the electricity, okay, if the ST segment here is coming up, okay, so in any area of the heart, if the ST segment is coming up, okay, this means it's coming closer to the camera or to the lead here, for example, to lead 3. It's coming closer to lead 3. And this means it will come away, or it will go further away from another camera, which is another lead. For example, here, let's say V2. So it came closer to lead 3, okay, and it has gone away a little bit from lead V2. Okay, this is what we call the mirroring effect. Okay, is this clear to now?
Yes, it's clear. Thank you.
Yeah, okay, good. This mirroring effect is called reciprocal changes or reciprocity. Okay, this is the name for it. Okay, so when we see an elevation in an area of the heart, we say, let's say, for example, in this example, we have an elevation in 2, 3, and AVF, and these represent the inferior wall. We will call the ST segment depression in other leads a reciprocal changes, okay, which means a mirroring effect as well. And this mirroring effect supports an acute ischemic change. If I can see a mirroring effect, then this gives me a support or give me a high suspicion that this change is an acute. Because if I lose this mirroring, okay, this might mean that this is not a significant change or this is not an acute change. Okay, so I can find in this ECG an ST segment elevation in 2-3 AVF, which represents the inferior wall with reciprocal changes in the lateral wall in lead 1 and AVL, and also part of the interior wall in V2 and 3. Okay, is this clear? Okay, good. Sure? Are you sure? Because you are going to try for yourself. Okay. Who would like to try? Isaac, it's been a while since you've tried something.
This one, right?
Yeah, this one.
Okay, so looking at this ECG, I think I can see some ST elevation in V1, V2.
Yeah.
Can see ST elevation in V1, V2, and V3, and V4 as well. Yeah.
V4. Good. Yeah.
Yeah. And then yes. And I think T wave inversion in AVL.
Yeah.
Yeah. So T inversion in AVL and then lead 1 as well.
Yeah. Okay. Good.
Yeah. Yeah. So I would rather think that there's an ECG changes in V1, V2, V3, V4, which is suggestive of
ischemia. Okay.
Inferior anterior STEMI, yeah. Something like that,
yeah. Anterior STEMI. Yeah. Good.
Yeah.
Perfect. Brilliant. Thank you. Yeah. So an ST segment elevation from lead 1, V1, sorry, to V4. And also, can you notice the AVR slightly elevated?
Yeah.
Okay. Yeah, and with ST segment depression reciprocally in lead 1 and lead AVL with T wave inversions in both of them as well. Okay.
Hold on, sorry, I can't see your screen again.
Again, so let's.
Or is it from me?
Yeah,
Can I see?
yeah, this is our TP line. This is the T wave. This is the P wave, and this is our baseline. Okay. And here is our J point. Is it elevated or depressed?
It's elevated. Yeah.
Yeah. Can you see it? Anyone has any doubt it's elevated? Let's apply the same here to lead V2. So this is the baseline, and this is the J point. The same here. This is the baseline, and this is the J point. This same goes to V3. This is the baseline, and this is the J point. Are they on the same line or not? Okay. And it also goes to V4, but a little bit lesser than the rest of them, of V1, V2, V3. Okay. And here, let's zoom in lead one. This is our TP segment. This is the T wave looks inverted, so it's obvious here. But if we can compare the J point to the TP line, we can find out that it is lower than the baseline. So it is depressed in here. Okay, you can say it's depressed also in lead 2, but it's not significant depression. And if we go here, lead AVL, you can see it is depressed as well. Okay. Does anyone have any questions about this ECG? Okay, good. We need another volunteer to try. Anthony.
Dr. Omar.
Yeah. Let's
Okay,
give it a try.
So looking at this ECG, lead 1, the beginning of lead 1 is not clear to me.
Yeah.
But I can see there is, when you move towards AVR, I can see there is slight depression, ST depression, slight ST depression.
Where is the J point?
The one I'm looking at is
So if you tell me there is an elevation of depression, I will ask you about the J point, the junction point.
Yeah.
Okay.
Yeah.
Is the junction point here? Okay. If we agree
Yeah,
to
that one. Yeah. I'm
is
looking
it
at
on
that
the
one.
line, or is it elevated or depressed?
Where you just put your pointer, that one. Yes. That's the J point. So looking at the J point and our reference line, I think it's slightly depressed downwards.
Okay.
ST depressed, slightly depressed. Yeah. And I cannot see any T wave inversion in lead 1.
Okay.
Yes. Lead 2, I can see that there is depression, ST depression there.
Yeah.
And then lead 3, there is T wave inversion and then ST depression as well.
Yeah, good.
Okay, so let's move on to the other ones.
Yeah. AVR, AVL, AVF.
AVF, there is a significant depression.
Yeah.
And then T wave inversion as well.
Yeah. Good.
In AVL, there is elevation there. If I'm right, there is elevation that I can see that ST elevation.
This is the J point, and this is the TP
Yes.
line.
So that
is it elevated?
No, it's not. It's not.
Yeah. Not. Okay. Good. Okay.
No.
And the AVR, can you see spot anything despite that the baseline is not the greatest, but
AVR is fine. It's
normal. Is there anything that catches your eye in it?
So, well, it's not. It's not clear to me.
Okay.
If I zoom it, it's not clear. Okay. But
let's
I
move
cannot.
The chest
yes.
See how it feels on the side.
So, I'm looking at V1 now. V1 there is ST elevation there.
Yeah.
Yes. In V2 the same. And then in V3, in V3 there is T wave inversion and then ST depression.
This we cannot.
Yeah, that's what I'm looking at.
This complex, so we will judge these two complexes. Okay, because this is the patient might just breathe or the lead might just move, and it will give you this, line, which is not a good thing, but sometimes it happens.
Okay.
Yeah. We have to judge or to take a very good, clear baseline that we can judge upon.
Okay. So that one too is not clear. So when I move on to V4, there is ST elevation there. Because looking at the baseline is just a little above the baseline, where your KESA is.
Yeah.
The other ones towards the end looks a little bit the same.
Mm-hmm.
Yeah, on the same V4. V5 there is no significant change in V5.
Mm-hmm.
And V6, I would say with the first one, there is slight depression.
Yeah.
And even the second one as well, the second wave as well. Yes. So we can see that we've got some changes at same area or same areas.
Yeah.
We've got changes in the lateral side and the anterior side as well.
Yeah. Good.
Yeah.
Yeah. Thank you.
You boss.
Thank you very much. I think you're now little. You can see that the ECG is less complex now than before. Yeah. Okay. So thank you for this interpretation. We can see that there is an ST segment elevation in V1, V2, and in these two complexes of V3, V4 as well. So we have a significant change, an anterior wall ST segment elevation myocardial infarction, and what we call it as TEMI. Okay, and with the reciprocal changes, which means an ST depression in the inferior wall. Okay, so ST segment depression in 2, 3, and EVF with T wave inversion as well. Okay. Okay. We would like to try this one. Let's say Josephine. Are you in a position to try?
Hello?
Yeah. Hello.
Yeah. Sorry, not at the moment, please.
Yeah, it's fine. Okay.
Sorry.
Okay. So we are looking at T wave inversions, ST segment depression, ST segment elevation. These are the three changes that we are looking for. Can you see any of these in which leads, in any of the leads? Okay. You can see that I have chosen a very difficult looking ECGs, just to make things a little bit harder. After that, you can use our lovely ECG machines. Okay, they are looks good. Okay, or better than these. Okay, ECGs. Anyway, so in this ECG, we are looking at ST segment elevation in lead 2, lead 3, and lead AVF. Okay, you can see that the G point is higher than the baseline in these 3 leads. And we are looking at ST segment depression in lead 1 and lead AVL as well. And we can say that we have V5 and V6. We can say that we have an ST segment depression or elevation, sorry, through from V4 and V5 and V6. Okay, but it's more clear in V5 and V6 than V4. Okay, so we can say it's an inferior wall STEMI, 2, 3, and AVF is an inferior wall STEMI, okay, including part of the lateral wall and with reciprocal changes in the lateral wall itself as well. Okay. Okay, what about V1? There is a slight ST segment, J point is slightly lower than the TP line. Okay. So this is a bit of advanced topic in this lecture. What's the correlation between ECG and coronary arteries? So each area usually is represented or does each wall is supplied by a branch of our coronary arteries. We have 2 main branches, right one and left one, and the left, each branch has 2 other branches. So right one has the right marginal branch and the branch to the ASA node and branch to AV node, the posterior branch. Left one has also multiple branches, but this is not our area to cover in this lecture because we are speaking about fundamentals, but this is just for you if you want to increase your knowledge about it. Okay, so let's just review what area is represented by which area, which is represented by which leads. So the interior leads is represented by V1 through V4. Lateral area is represented by V5, V6, and lead 1 and AVL. And the inferior wall is represented by 2, 3, and AVF. And the right wall that we usually forget about, okay, is represented by the AVR. Okay, for a conclusion, always, okay, depend on your patient complaint. Okay, if the complaint, and start from it, if the complaint takes you towards ischemia, then it is ischemia until proven otherwise. If the complaint takes you towards arrhythmia, then it's arrhythmia until proven otherwise. If the complaint is not correlated, okay, and we have done the ECG just to make sure that everything is right, then most likely we won't get anything out from our ECG. And the complaint must, if we will do an ECG, then it must be accompanied by enzymes. If we are thinking about ischemia or that is something affecting our heart. Okay, thank you for your attention today. Okay, hopefully you have enjoyed and you learning, you have more knowledge, and this will make you better okay, healthcare professionals. Okay, I'm looking towards seeing you all in the shop floor. Has any question, I'm available, okay, almost most of the days. Please ask me any question if you have right now.
Hi, hello.
Yeah.
Yeah. Well, it's not really a question because I joined late, so I think I missed some of the basic things you said in the beginning. I don't know if it's possible to have access to the presentation.
Yes, I will send you a copy of the presentation, and I have also recorded both parts, the first session and the second session. Okay, but it takes some time for the teams to re-upload the recording. I will send you a message, okay, on
Alright.
the chat when it's
Okay.
ready.
Okay.
Okay.
All right. Thank you.
Okay. Thank you.
Thank you, Dr. Omar, for
Thank
the
you
wonderful
so
presentation.
much.
Yes, you.
I really enjoyed the presentation, and it's a lot clearer to me now. At least when.
Yeah. Yeah. Okay. Good. This will make
Thank you.
ECG an
Bye.
ECG go.
Thank you.
Yeah. Okay.
I just want to ask you, are we gonna have like another ECG class again?
Yes, we will have another ECG class. Okay. But
Because I want to be clearer. I work in ED and for like resuscitation, you know, sometimes based on the ECG, you have to do shockable or non-shockable shocks and all of that. And I was really finding it a bit difficult understanding which ones, the type of ECGs and the shocks and all of that. So I don't know if we're going to have another lecture to cover those.
Yeah. There is the other part of this lecture. We will speak about arrhythmia. Okay. Speak again. Yeah. So the tachyarrhythmia, when to shock, when not to shock, who needs shock, who doesn't shock. Okay. This is the second part. Okay, of ECG. Okay.
Thank you very much.
Thank you. Thank you. I have sent you the link for feedback. Okay. And this is the QR code. Please tell me in your feedback what have you learned and what was the strength is, what was the points of improvement. If you need any other extra material, if you need any other lectures, I am happy to do whatever you like, okay, or whatever you need. So in the next lecture, we have at least one other lecture, which in which we will cover the arrhythmia part, okay, and depending on what you need, we can complete it by a third one, okay, to speak about the unusual patterns either in arrhythmia or in ischemia, if you are interested, or if you would like to do so. Okay.
Thank you. The QR code for those of us that used our phone, I'm trying to. I don't know how to.
I have sent a link on the chat. If you just open the chat, then you can go through the chat directly. Okay, if you have difficulty.
All right, thank you. Okay.
Okay. Thank you all for your time.